Welcome to our session, Cardiology, Atherosclerosis, Regenerative Repair. Let's see what nanomedicine has to offer for cardiology. We start with Professor Harald Mangge from Austria. So he's from NanoAthero project. And he will talk today for personalized medicine for atherosclerosis, relevance and prospects. So, Professor Mangge, the floor is yours.
Ladies and gentlemen, fine to talk to you now about this topic. Let me share with you in the next minutes some thoughts about this phrase, personalized medicine and the relevance and prospects possibly for atherosclerosis. As you can show on this slide, there are rather different phenotypes which show a common denominator. These different people shown here, they all suffered from a destabilized vulnerable plaque which caused an acute myocardial infarction. And so there is a rather different time of diagnosis of this clinical endpoint in these different phenotypes. And also the clinical course of disease was very different in these people, not the better one in the younger and more sporty people who suffered from this clinical endpoint. So they all showed a vulnerable atherosclerotic plaque. And I think that the immune-mediated inflammation, the activation of the immune system is very important for a better understanding of this disease from which we think that we know so many details. There are several aspects coming from the immune-mediated inflammation will be very important in future also. These vulnerable plaques are usually non-stenotic, so you cannot diagnose them easily before the endpoint occurs because contrast agents will not help you very much, and also intravascular ultrasonography also will not help very much to diagnose it. So we really need biomarkers. We really need biomarkers to identify this sheet lightning anteceding the thunderstorm. This slide shows you there are so many biomarkers. There's only a few biomarkers of those who are used in research, and many of them were seen as very useful. But unfortunately, if we consider the relevance for the clinical diagnosis and therapy of cardiovascular disease, very few biomarkers are left which are useful, and so we have to improve. If we want to improve the personalized medicine, genetics are very important. This is also true for cardiovascular diseases. But if we consider genetics in cardiovascular disease, there we have to consider a very complex interaction of many separate genetic and environmental effects. All of these conditions are moderately heritable, but the genetic susceptibility is due to small effects at many genetic loci rather than large effects in single genes. Some advances had been made largely due to genome-wide association studies. Examples for this are PCSK9, SNPs, in this gene associated with cardiovascular disease in genome-wide association studies, and a novel drug was developed to reduce LDL in familial and non-familial hypercholesterolemia. This was a great effort and little more use. SORT1 is also brought in, the overexpression of SORT1 is brought into connection with drastically reduced LDL and VLL levels, and novel drugs are in the pipeline for the treatment of hyperlipidemia. This may be useful for cardiovascular disease. Some success comes also from the pharmacogenetics if we consider the clopidogrel resistance. But there is not very much more in cardiovascular disease. So I think that we have to concentrate more in the future to the immune-mediated inflammation. We all know that the antigenic presentation and the initiation of the process is associated with the role of macrophages. Macrophages are in a complex manner involved in the cardiovascular disease. You all know about the many data concerning the polarization of macrophages, which seems to play an important role. This is a very complex Janus phase of the macrophages with very different subtypes far beyond M1, M2 subtype, and these complex interactions have to be better understood in the future to provide a more personalized view of the pathologic process. It is, if we consider the role of LDL, the grade of the LDL oxidation important for also this polarization of macrophages. One may consider ox-LDL is a bad influence, but there is also positive influence if we consider the activation of M2 subtypes, who are considered rather protective in reaction to oxidized LDL. Also, HDL and the pyroxenase in HDL particles is important in these connections. So we have to improve the understanding of all of these networks. Very important, the immune system, I think, is very important to improve the understanding. Behind the macrophages, you have to consider the T cells with their complex interactions. And if the time is too short to go into details here, but I want to underline the critical amplification of the inflammatory response, not in the plaque, but in the draining lymph nodes and spleen. Please consider in this case also the gastrointestinal immune system and the microbiome interaction. This is very important, and improved understanding of this critical amplification outside of the atherosclerotic plaque. T cells and the polarization of T cells are very important, and the priming of T cell happens in secondary or tertiary lymphoid tissue by antigen-presenting cells. And again, consider here the influence of oxidized LDL, specific T regulatory cells, which can inhibit the progression of atherosclerosis in this complex network here. So the problem, as you all know, is in this case that the great part of the available results originates from mouse models, and what's the relevance for human systems. So I want to concentrate in some few slides on the human situation and on the data concerning toll-like receptors. You all know that toll-like receptors are very important. This is in cancer disease. This is also true in inflammatory atherosclerotic disease. And it is important for the macrophages, for this main waiting cells and very responsive cells for the atherosclerotic process. If we consider toll-like receptor 7, there is a protective attribute of this toll-like receptor, because an increased expression of TLR7 is associated with M2 macrophage markers and stabilization related genes. And so I think that the toll-like receptor and increased understanding of the toll-like receptors is important for this progress also in personalized diagnosis of the atherosclerotic disease. So in the end of my talk, I want to concentrate very short to some interesting biomarkers in blood and in the plaque. I want to suggest in this connection trimethylamine N-oxide as a very interesting biomarker because it builds a bridge from the nutritional behavior and the microbiome, and this trimethylamine is metabolized by hepatic flavin monooxygenases to the dangerous trimethylamine N-oxide, which again activates the macrophages in atherosclerotic lesions and also influences the polarization of macrophages. And so there is a link which is interesting because the MAO and the dimethylamine N-oxide may be responsible for atherosclerosis in people who show normal lipids, normal and very good function and HDL, and so it may be a new pathway for understanding the atherosclerotic process as shown here. And at the very end, I want to suggest one interesting biomarker, pentraxin 3. Pentraxin 3 is especially found in vulnerable plaques and not in stable plaques, as shown here. It was recently shown that plasma pentraxin 3 levels associated with plaque vulnerability also concerning the blood levels of this pentraxin. So I come to the very simple take-home message. How can we diagnose a vulnerable atherosclerotic lesion at the right time in a still asymptomatic person, a patient? This is a remaining challenge and question. And how to treat these persons effectively without side effects. Any complication in a yet healthy person is unacceptable, and I think then improved understanding of the immune-mediated inflammation based on the interdisciplinary cooperation between laboratory medicine, nanotechnology, and radiology will be helpful in this context. And I hope that we'll hear some new data also from the nano-arterial project now in the next talk, which give some new hints in this direction. Thank you very much.
So, questions?
Your observations about the trimethylamine oxide or your PXT3, do they give insights into targeting mechanisms that nanoparticles might use?
This is a very interesting question concerning DMAO. I think it is too early to speculate about this. I think DMAO will be an interesting diagnostic element to identify atherosclerosis in non-Framingham risk patients. And concerning pentraxin, it can be thinkable because it is a specific biomarker found in active inflammatory lesions in the vulnerable, in this plaque where the clinical endpoints occurred. And so to combine it with liposomes, for instance, by covalent binding and to transport some anti-inflammatory drugs with this targeting molecule can be a thinkable approach for the future.
Thank you for your talk. Nice talk. You propose some biomarkers for vulnerable plaque in patients, but How strong is always the clinical evidence that a plaque is vulnerable? How is that assessed? Is there very strong evidence for that, or is that also still quite experimental?
This is a central question. What is the vulnerable? What is the culprit lesion? And what's the process which makes the lesion from a ticking bump to an active bump? I think that the quality of the immune-mediated inflammation is important, and I think the toll-like receptor will help to improve the understanding of the processes which are associated with stabilization, because they are so central for the innate immune response. And so it is thinkable that in people who have polymorphisms for the toll-like receptor response, plaques may be more unstable as compared in other patients. So that if we have atherosclerosis as a unique response in many people, but if we look at the individual inflammatory immune response, it may be different in some disposition with responses of toll-like receptor expression, and so this will cause more unstable lesions. This may be thinkable because toll-like receptor 7 increased expression is associated with a more stable stabilizing inflammatory response, and a better understanding in this direction may help.
Thanks for your talk. You did mention what is important is the balance between how the immune system is activated and anti-inflammatory cells recruited to the plaques. Now, considering the macrophages that are playing a very important role in the plaque development, is there any evidence for the role of intracellular pattern recognition receptor rather than toll-like receptors, such as NLRs or NOD, in processing or for the oxidized phospholipid to interfere with the signaling process?
This is true. If a macrophage reacts more as a farm cell, which undercoats explodes and destructive enzymes are set free, it is thinkable that also the lipid peroxidation and other influences are maybe responsible for this, but it is much more complex in reality, because I showed you that oxidized LDL, which is considered more a bad guy, acts stabilizing, influences to some extent the macrophage polarization to more stable subtypes, to more M2 reaction. But many from this understanding is too simple. It comes from mouse experiments, and the human situation may be much more complex. So I think there is much research to do in the future to improve the understanding that you can find out the constellation which may be dangerous and diagnostically fix it for an individual person. I think it's much research had to have been done for the future to improve the understanding.
If not, thank you, Professor Mangge.
Thank you.
Now we are moving to the second speaker.